This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. Now, how do you manage when you are surprised by an intraoperative zonular dehiscence? This video is all about it. Now, he is a 63-year-old gentleman who has long-standing diabetes. He also has diabetic retinopathy and he needs to undergo a vitrectomy for that. But before that, we are planning a cataract surgery, and this is how the eye looks. We have a small central area of subcapsular fibrosis, and it doesn't look to be very threatening at this point. So my plan was to just do the rhexis around it, and then that should be fine. That was my assumption. The capsule is stained. Now is the time to perform the rhexis. I make a puncture with a 26 number needle. A flap is raised, and my plan is to tear it around the area of fibrosis. I don't want to involve that area of subcapsular fibrosis. And as I reach this quadrant, the capsule is refusing to tear. It's a little bit uncontrolled. I switched to my forceps, and it gave me better grip, and I could complete the rhexis. Although it was slightly bigger than what I would have liked, but still it's better than having none. So now is the time to do hydrodissection. I'm just doing hydrodissection. I'm trying to decompress the capsular bag to let out the fluid. To my surprise, I realized that the hydrodissection is not really freeing up the nucleus from its attachment to the capsular bag. So I go and refill with the chamber with OVD. I'm just trying to use my sharp chopper, just trying to nudge the nucleus around and to see whether I can mobilize the nucleus, but it doesn't seem to work well. So this clip really shows us how important it is for us to hydrodissect in such cases. I go back and redo the hydrodissection, and chamber is refilled with OVD, and I'm going back with my sharp chopper to move the nucleus around and see, and I'm trying to do the tangential rotation. I'm relieved to note that the nucleus is moving around without disturbing the bag. So it looks to be alright now. So let's emulsify the nucleus and finish the case. That's what I thought. So in diabetic cataract, sometimes the nucleus can be crumbly. So I wanted to do divide and conquer technique in this patient. The nucleus is stabilized with my second instrument as the primary trench is being created. When it reaches about 60 to 70% depth, the nucleus is gently rotated using two instruments. Note my chopper as well as my phaco handpiece are nudging the nucleus for rotation, and this definitely helps in minimizing the stress which is being induced on the capsular bag. The third groove is created. Nucleus is again rotated. The original groove is then deepened and lengthened. I always prefer to stabilize the nucleus with my second instrument. This is going to help us especially when you're dealing with a mobile nucleus. So make it a habit to stabilize the nucleus with the second instrument. Now I'm trying to do the fourth groove. And I think now it's deep enough. I'm going to attempt lateral separation using the phaco tip and the sharp chopper itself. The first crack is done. Nucleus is rotated and the second crack is being performed. The nucleus is not hard or not too soft. It can be cracked quite easily. So now we have got 4 pieces and looks like a job easily done. The first fragment is pulled out of the bag and then emulsified. As the bag gets empty, the bag in the area away from me seems to be collapsing on its own. Looks to be having a zonular issue in that quadrant. So let us see. I thought I'll just emulsify this fragment. And before coming out, I'm going to inject OVD so that I don't want the chamber to shallow and the bag to collapse. So this is an important tip here. So when we're having a localized zonular dehiscence and you want to come out, never allow the chamber to shallow. The bag, if it collapses, then there is always a chance that the zonular dehiscence can worsen, and there is also a risk of the vitreous prolapsing out through the zonular weakness. The last 2 fragments are then consumed in the central safe zone. And before coming out, again I'm going to inject viscoelastic into the eye so that the bag does not collapse totally. The bag is now being refilled with the OVD so that I can complete my cortex aspiration, the remaining quadrant. There is a small plaque of cortex in the area of zonular dehiscence, but I wouldn't want to touch it now. Once the remaining cortex in the other quadrants are taken care of, I thought the first thing to do now is to stabilize the bag by putting in the CTR. Again, the bag is refilled with OVD. This time I'm going to use sodium hyaluronate. Let me pause here for a moment. The best way to inject a CTR in this case is to use an injector and inject with a left opening CTR so that we can directly support the area of zonular dehiscence from the beginning of insertion of CTR itself. But even if you don't have an injector CTR, if you want to insert the CTR manually, well, it might be difficult for us to reach that area first, but it shouldn't be such a cause for concern. So don't be so unusually perturbed. So why would we recommend to insert the CTR beginning at the area of the zonular dehiscence first is that during manipulation of the CTR, we don't want the area of the zonular dehiscence to increase. So that's the whole purpose. So when we're doing it manually, it might not be possible for us to support the area of zonular dehiscence first. But in this situation, one trick to minimize the extension of the zonular dehiscence is fill the bag with a lot of cohesive OVD. That itself will maintain the space and prevent the bag from collapsing as the CTR is being threaded. So as we can see, my CTR threading is in the usual form. I'm going through the side port. And to ensure that the area of the zonular dehiscence is well and truly supported, I want to ensure that the CTR ends way beyond the area of zonular dehiscence. So that's what I'm trying to do it here. I'm trying to dial into a position so that the area of the zonular dehiscence is very well supported. In this case, the pupil is very well dilated, so we can clearly visualize how to ensure this. I prefer to use a dialer, hook it on the eyelet, and then dial it to ensure that the ring is in the right place. The planned multi-piece lens is being placed into the bag. The OVD both in front and behind the lens is removed. The eye looks to be good. Just to add a little bit of more strength to the area of the zonular dehiscence, I want to ensure that the haptic is in the area of zonular dehiscence. And that's it. The wounds are treated. That's it. The case is done. So that was it. Thank you for watching and hope you found this helpful.